big welcome to everyone joining us for our NSDA Virtual Symposium. As most of you are aware, we were scheduled to be in Detroit today and conducting our symposium in person, but due to the coronavirus pandemic, it's certainly changed all of our plans, and so we decided to conduct this virtual symposium. We felt it extremely important to maintain connection with all of you in our community, and so we have a fantastic program put together today to share a lot of information and give you an opportunity to ask a lot of questions. And we have just a lot of medical personnel who will be participating in the symposium as we go through the day. A couple of quick comments, highlights from our year just finished for the NSDA. It's extremely exciting to see the level of activity in research, and we received a number of research grants during the past fiscal year, which just ended on March 31st. And later today, you will have an opportunity to hear from the research teams, and in particular a research team that we just funded at the end of this past fiscal year. So a lot of activity from other research teams, and for those of us who have lived with a voice condition, and specifically SD, for many, many years, looking at the level of activity in research over the past few years, and literally very few years, is just heartwarming and absolutely exciting. One other quick highlight for our organization from last year is we rolled out our new website, and we had been working on that for a period of time, but we are extremely pleased and excited about the new website. And if any of you have not had the opportunity to check that out, very simply go to dysphonia.org, and you will find a wealth of information and a lot of materials that you can utilize as we all cope with and live with our voice conditions. So take advantage of the website and use it and utilize it. It's not only a great support tool for those of us in the patient community, it's a fantastic resource for our healthcare professionals as well, because we have a very active healthcare referral listing. And one of the interesting things here in the past couple of weeks is the number of people, physicians and SLPs, who have contacted us to add telemedicine to their profile. So one of the things that's come out of the pandemic issue here. So utilize the website to take advantage of it, and let us know if there are things that you would like to see on the website or information there. You can certainly consider that. I want to take just a second and give just a huge shout out and thank you to all the healthcare professionals that we have an opportunity to work with in our organization. Just some of the most incredible people that you could ever have the privilege of knowing and working with. And I can't thank all of the laryngologists and SLPs, not only across this country, but in other countries that we work with, and just a tremendous amount of support and help that all of you give to us. And as evidenced by today, with you participating in this symposium, taking away time from your family, and especially in this pandemic situation, is just another indication of what a great group of people you are, and I can't thank you enough. So, a couple of quick things. For those of you watching, the presentations are up on our NSDA YouTube channel. So as the day goes along, you can watch all of the presentations that are going to be referred to and talked about, in addition to some other materials that are up there. So take advantage of that and utilize it. So with that, we're going to start with our first panel of clinicians, and I'm going to ask Dr. Berke to briefly introduce himself and give us a bit of an overview and the key points from his presentation.
Thank you, Charlie. Thank you so very much. Thank you to everyone for allowing me to participate this morning. I'm farther away than you guys are. I'm the scientific director, really, of the NSDA, which is a giant honor for me to be able to say. And as usual, I get to kind of comment on surgery for spasmodic dysphonia, although I should say 95% of the people that I have the opportunity to take care of do very well with Botox and never really talk very much about surgery at all. But having said that, my presentation presents two aspects. One is bilateral thyroplasties for mild to moderate adductor dysphonia, which I think can certainly be an adjunct to other therapies that exist. And of course, I didn't really talk about myomectomies and other surgeries, although I was, who else was presenting this morning? But I also talked about SLAD-R, selective laryngeal adductor denervation and reinnervation. And if you're interested in taking a look at those, I think you should be able to find it on the website.
Okay, Jerry, thank you very much. I appreciate that. Dr. Gardner.
I'm a laryngologist at Henry Ford Hospital in Detroit, Michigan. I trained in Nashville with doctors Ossoff and Netterville, and have been practicing here for 25.5 years, taking care of spasmodic dysphonia patients that entire time. We had a clinic established by Dr. Michael Benninger, who was our chairman at the time. My talk today, was on Botox injections for spasmodic dysphonia. I gave a brief overview of spasmodic dysphonia and then focused on Botox injections for adductor spasmodic dysphonia, leaving some of the other conditions, tremor, abductor spasmodic dysphonia, false focal fold injection, to my colleague, Dr. Mayerhoff, who's also on the panel. I think that's about it. It's an honor to have been invited to participate, and hopefully next year we'll do this live in Detroit when it's safe.
Great, Dr. Gardner, appreciate that, sir. Thank you. Dr. Rubin.
Hi, I'm Dr. Adam Rubin. I'm a laryngologist and director of the Lakeshore Professional Voice Center, which is part of Lakeshore Ear, Nose, and Throat Center in St. Clair Shores, Michigan, just outside of Detroit. I work in tandem with my better half, Juliana Codino, who you'll hear from shortly, our voice pathologist. We treat all voice disorders and have a hearty spasmodic dysphonia and tremor population, which we really take great pleasure in taking care of. We were asked actually for this conference to talk about vocal fold paralysis, so a slightly different issue, although Botox can cause vocal fold paralysis, interestingly enough. But in any case, we talked basically in tandem about diagnosis and treatment and the various treatment options, including voice therapy to various surgical options. So I hope you enjoyed it if you got to watch it.
Thank you, Dr. Rubin. Appreciate that, sir. Juliana.
Hi, everyone. First of all, well, thanks. It's an honor to be here. Thanks for the invitation. And as Dr. Rubin said, we work in tandem here at Lakeshore Professional Voice Center. As a multidisciplinary team, I work mostly with spasmodic dysphonias after he's done the Botox injection, trying to maximize the effects of the Botox with voice therapy. Some patients, when we don't know, we're not sure if that's the diagnosis, we do a trial of therapy first to try to make the differential with muscle tension dysphonia. And as Dr. Rubin said, our presentation is on hypomobility of the vocal folds. So I touched there a little bit about voice therapy and how we treat patients before, after, or only with voice therapy if they had any surgical intervention for the paralysis or paresis.
Great, Juliana. Thank you so much. Thank you for joining us and all that you do. Appreciate that. Dr. Mayerhoff.
Hi, my name is Ross Mayerhoff, and I'm also a laryngologist at Henry Ford in Detroit, in the city itself, in the metro area. And like Dr. Gardner, I treat spasmodic dysphonia among other neurologic voice disorders. My talk was focused on alternative approaches to Botox, focusing on when the more standard approach doesn't work well for a patient, and then also some related conditions like tremor, abductor spasmodic dysphonia, and actually bilateral vocal fold paresis, hypomobility, or synkinesis when the vocal folds are not opening as well, and discuss how Botox can be used for all of those situations as well.
Great, Dr. Mayerhoff. Thank you very much. So we will now move to the Q&A session, and I encourage all of you to send us your questions. I know that you have questions when we do our in-person symposiums. There's always lots of great questions. And just a reminder that if you have a question, I will assure you that there are at least a few other people who are probably thinking about the same thing that you're asking your question about. So send us those questions, and let's get our clinicians here to respond to them and give you additional information. So get those questions coming in here, folks. Alrighty, let's start with, we had a couple of questions earlier. Kim, you want to restate those early questions we had?
Sure, absolutely. I'm Kimberly Kuman. I serve as the Executive Director for the National Spasmodic Dysphonia Association, and I just wanted to personally welcome everyone also. This is the first time that we've done something like this, and I just can't thank all of our speakers for accommodating us and recording the presentations. As Charlie mentioned, we have over 6 hours of content for you to explore and enjoy. They're all available in a playlist on our YouTube channel, and the link is in the chat. So we're going to start out with a question. I think I'm going to direct this to Dr. Rubin and Juliana, because the question is, what physical evidence do MDs, and I would say SLPs, use to differential diagnose between muscle tension dysphonia and neurological spasmodic dysphonia? It seems like it's a team approach kind of question.
Absolutely, it's a great question. I would say the most important element of physical exam in terms of distinguishing between the two and making either diagnosis is listening to the voice. Now, spasmodic dysphonia should be a task-specific dystonia. It should be, certain tasks will trigger the spasms, and those tasks are different for adductory and abductory. Whereas muscle tension dysphonia, you'll probably hear that tension more constantly, less task-specific. Now, sometimes it can be complicated because there can be a muscle tension element over spasmodic dysphonia, and sometimes it's difficult to break that. We look at the vocal folds as well. We do flexible laryngoscopy, video stroboscopy, obviously, and in a muscle tension dysphonia, you might see more regular, constant hyperadduction, excessive closure of the vocal folds throughout the entire, voice sample. So that can help, and also looking at the vocal folds helps us rule out other problems. But we'll also, during that exam, put people through a variety of distraction tasks, and there's certain things which, classically have been described to make a spasmodic dysphonia voice sound better, high pitch singing, things like that. Unfortunately, that also can make someone with muscle tension dysphonia sound better as well. So in any case, we have very low threshold. We work as a team. I often will put them in Juliana's or one of our voice therapists' hands to see if they can, quote, break any muscle tension component. And what's critical there, you know, in terms of that decision point as to where we're going to go, because there really otherwise is no gold standard to spasmodic dysphonia. Whether or not they're going to get a Botox trial or not will depend upon, one, whether therapy can break the voice pattern, and whether the patient can maintain it. And I'll pass it off to Juliana to let her add to that.
Yeah, so the day of the first day that patient comes to the office, as Dr. Rubin said, we pay attention a lot to what we hear and when we hear that particular affected output in his voice or her voice. And we try different distraction techniques. When he said that, we try lip trills, we try humming. Usually with those techniques, if it's a muscle tension dysphonia, we will hear some clearer voice. Sometimes patients are we are not sure, and we tell the patient, we are not sure if you have one or the other. So we go through sometimes 2 sessions of voice therapy, 1 or 2 sessions of voice therapy. And when we see the patient back, if after 1 or 2 sessions, if there is absolutely no improvement, we think that we are in the presence of a spasmodic dysphonia, we discuss Botox. We typically discuss it before, but as Dr. Rubin said, the threshold is kind of, we're not too tolerant in waiting for the improvement, because muscle tension dysphonia typically responds very well to voice therapy, and spasmodic dysphonia doesn't.
Wonderful. We've got a lot of questions, so I'm going to just keep moving through them. Dr. Gardner, can you build up immunity to Botox?
Well, considering the very small doses that we use in the vocal folds, the likelihood of building up immunity is very, very low. So there's very low antigenicity, meaning that the Botox does not stimulate your immune system to develop antibodies that will then eat up the Botox when we inject. In other conditions, certain other dystonias where they're using very high doses, such as 300 units in very large muscles in the body, you can develop that. But we use the largest dose I think any of us ever use is going to be 15 units, 1.5. And so we use very small doses, and it's really not something that's noted with any great regularity. One of the studies that I cited in my talk was from Dr. Blitzer, who clearly has the most experience with this, where he showed that the likelihood of a patient requiring more Botox over time was about equal to the likelihood that they would require less Botox over time. So he saw no regular trends for people who needed more and more Botox. So it's not likely. That's the short answer.
Tim, on that topic, though, I think people who are getting Botox for spasmodic dysphonia should think long and hard before going to get Botox for cosmetic reasons, you know, for wrinkles and things like that, because those doses are much higher, so they put themselves at greater risk for developing resistance.
That's a great point. Thank you. Dr. Berke, should surgery be considered a more permanent cure than Botox if Botox is working satisfactorily? What are the risks? What are the upsides?
Well, okay, thank you. It is more permanent in the sense that once the operation is over and patients recover and their voice returns, it seems to be pretty consistent. We have patients that we've operated on back in the very early 90s that continue to have good voices, and I hear from them every now and then. They'll send me little thank yous around Christmas time or Easter or whatever. The risks that occur with any type of a 3 or 4 hour operation, and it's something that, you know, patients have to take into consideration. What was the other aspect of that you asked me about in that sense?
About the risks about surgery.
Yeah. Well, you know, not every patient that has the surgery ends up with a great voice. You know, I mean, we've looked at the data now over a long period of time and published a number of papers on our results, and it looks like a good percentage of patients can end up getting good usable voices, and they're very happy. I think the other thing that's important is that for patients that don't end up with loss of spasms, which happens probably in about 10 to 15% of patients, they can go back to the injections. And I have some patients in my practice where for whatever reason, it didn't seem to work and they are able to go back to the shots, which I think is an important thing to take into consideration whenever you undergo any type of alternative therapy for this disorder.
Thank you. Dr. Mayerhoff, what are your thoughts about injections into the false vocal cords for adductor spasmodic dysphonia?
Unmute myself. So in general, it would not be my preferred or first approach for most people. I brought it up in the talk in particular because some people have found success with this. Dr. Blake Simpson, now in Alabama, has published the most on this. The idea of it is that a bit of a larger dose and it's slightly away from the true vocal fold rather than directly into the muscle. So think of it as a more gentle onset, a little bit less breathiness. But the downside is that it's a little less precise, and it also can take longer and be a little bit more uncomfortable because of the way it's approached with the scope either through the nose or mouth, needing to completely numb up the larynx rather than fairly quicker injection through the neck. But like some of the other alternative approaches, it's useful to have that as an option if the primary treatment of direct injection into the muscle is not working well for the patient.
But Kim, there are some patients who, sometimes it's very difficult to discern the muscle tension versus SD. And there are some patients where it seems like it sounds more like a muscle tension dysphonia, but they're not able to be, fixed with therapy or they can't maintain it. And I find that sometimes those patients do, and it may be that there's a true dystonia there. I don't think we understand everything about dystonia. Maybe it doesn't always present in the classic way, but I find many times those patients do respond well to the false vocal fold injection.
Well, that leads into the next question. What is the best treatment for muscle tension dysphonia?
I think that
Juliana,
should
you want
be
to
answered by Juliana.
So, well, there's lots of evidence-based practice for muscle tension dysphonia. Any situation where the patient is adding compensatory hyperfunction, that can be from mild to a mild hyperfunction or complete aphonia, because they're adding so much strain that there's absolutely nothing there. There's laryngeal massage. That's one of the initial things we try, laryngeal palpation, see how much tension we feel in that neck, see if we can alleviate a little bit of that tension initially with laryngeal massage. Of course, we do it to the patient in the office. We teach the patient how to do it, so they can do it at least twice a day, 5 minutes each time they do it. Then we do all of our famous semi-occluded vocal tract exercises that really help in getting rid of all that maladaptive hyperfunction. This basically exercises phonating through a straw, sometimes with a cup with water at the end of the straw, sometimes without the water. Initially, I like to start with the highest resistance possible, so I include the water from the beginning. And see if we can coordinate better how much air and voice they're putting in each glottal cycle. Because in a hyper or in a muscle tension dysphonia, that balance is actually not a balance. It's a lot of tension and almost no air. So with the feedback that the patient gets from the bubbles or the air flowing into their hands, if they're not using water, they can track how much air they're adding to their voice. So I always tell them, you don't need a voice therapist beside you when you work at home. You have the bubbles, you can tell how much air you're using. You have your ears, you can tell if you're adding voice to those bubbles, and try to keep that airflow consistent. Then there's all sorts of resonant voice exercises in the big umbrella of resonant voice therapy that we also use to maximize the use of the resonator. So we unload the oscillator. So that would be the vocal folds down here. So all of the exercises that help the patient use those natural amplifiers we have up here in our vocal tract will unload and help reduce the impact stress that the patient does down there. And those are just to mention a few. I don't know how long I can stay talking about voice therapy for muscle tension dystonia, but an overview would be trying to get rid of that hyperfunction and coordinate better the balance between the three subsystems: air, breath support, the vocal fold oscillation, and the amplification up here.
Thank you.
No, the term muscle tension dysphonia can be applied to so many clinical pictures, right? So maybe all of us at the end of this talking into a computer are fatigued and a little hoarse afterwards. Well, there's a muscle tension dysphonia aspect to that. And then on other extremes, there are presentations which I like to refer to as functional dysphonia, where it's almost like a true conversion disorder, where there's something internal which is, you know, causing the patient to create an abnormal voice, but there's not a true dystonia. So I mean, so I have trouble with when we talk about primary muscle tension dysphonia, because it really can cover so many different clinical presentations.
There's a lot of spectrum there.
Yes.
All right. So here's a timely question for Dr. Gardner. I'm unable to get my Botox injections because of the pandemic. If I don't have a regular injection, will it have a long-term adverse effect on the quality of my voice? That's something that a lot of people are facing right now.
I really don't think that it does. I find that I have patients who have dropped off the schedule for long periods of time in the past, either because they moved to some place where they could not get injections for a long time. Excuse me one second. My wife has the computer going in the other room. But in any case, so they go for long periods of time without getting injection, either because they lost their insurance or they moved to a place where they couldn't get it. When they come back to me and start getting injections again, we pick up pretty much where we left off. They respond well to the injection. I usually don't even change the dosage. So for people who currently are not getting their injections because of the pandemic, they will of course suffer more for a longer period of time with their abnormal voice until they get treated. And many of our patients are quite frustrated by that. I have to say that I've continued to inject my patients here at Henry Ford during the pandemic. We're doing it in a safe manner. I have patients wear a mask when I do the injections. I do all my injections percutaneously through the cricothyroid membrane. So they wear a mask. They really can't cough on me. I, of course, wear all the gear that Dr. Mayerhoff showed when he gave his presentation, wearing a face shield and all sorts of extra precautions so I protect the patient from me. So the short answer is that I think that if they go longer, they will not suffer any long-term damage or get behind in their treatment.
Great, thank you. And just out of curiosity, for the physicians on the panel, how many of you are injecting currently with the pandemic? I know, Dr. Gardner, you are. Dr. Berke, you are still. Dr. Rubin, are you still injecting?
Not yet. It's a tough question because there's so many, although for adductor, the method I inject shouldn't induce cough, but it's still possible. And it's, we can protect ourselves, we can protect the patient, but the question is, if someone comes in asymptomatic but has COVID and it's aerosolized in the air, we don't know how long that's gonna stay there. So are we protecting the next patient? So I'm torn with this because obviously a lot of patients are suffering right now and can't get back to work. So we are probably going to start, or at least offering. I've even debated whether we should be doing this in the OR for a time being, just for negative pressure. I don't think we will. Maybe for the abductor patients where we have to do a transtracheal injection. But it's a tough dilemma. But I feel for the patients. So at some point we're going to have to move forward.
Dr. Berke, part of your presentation for this session was talking about the bilateral vocal fold thyroplasty for abductor. And so one of the questions is, does it stay effective for many years, like 10 years? And also you recommended it for mild to moderate abductor SD. What about severe cases?
Fortunately, from the patients that we looked at, it has, because some of them were actually done a number of years ago, probably at least 10 years ago, and they continue to have a reduction in their symptoms over that time period. So that's encouraging. By the same token, early on, we did try it on some patients that had severe cases of abductor dystonia, and sadly, it didn't really seem to affect them enough. Typically, before I recommend it to one of them, I will do an in-office vocal cord augmentation injection, which I can just do, with the patient in the chair. And then I'll see them back in about a week or two. And if they say that, my voice got better when you did that, then sometimes they can be a candidate for the bilateral thyroplasties. Although even in the severe abductor case, there have been patients where they seem like they've improved somewhat with the injection, but then after the bilateral thyroplasties, they didn't seem to be as improved as I would have liked. So I think it's only fair to recommend that surgery for people with mild to moderate cases of the disorder.
And can you just reiterate which surgeries are for what form in the presentation that you gave today?
Right. So, there's an old saying that dermatologists have, that, you put steroids on it, you can't do anything else. And basically the laryngologist has two choices. He can either make the vocal cords weaker, or he can try and make the vocal cords stronger. And so depending upon the disorder in spasmodic dysphonia, if the vocal cords are too tight, as in the adductor form of the dystonia, the goal is to try and make the vocal cords weaker so that they can pulmonary expiratory pressure more closely. And if the vocal cords aren't quite tight enough, like in abductor dysphonia where a lot of air is wasted, then the goal is to go ahead and make the vocal cords more tight. And so basically the bilateral thyroplasty kind of serves as a way of increasing the stiffness of the vocal cords. Exactly how it works, I allude to in the discussion, but I think it has something to do with the fact that when you push them closer together with implants, it sends a signal to the brain that the vocal cords, you have to use more pulmonary expiratory pressure to overcome the extra stiffness of the vocal cords. And for whatever reason, that seems to improve the quality of the closure more quickly. And so I think that's probably why the procedure seems to be effective in those cases. But sadly, some patients have such horrible cases of abductor that it just is not a good treatment for it.
Thank you. Dr. Rubin, what percentage of incidence of Botox what is the percentage of incidence of Botox-induced paralysis? Do we know that?
It's very low, and I hope I didn't scare people off with my comment at the beginning. It's very low. We always start with very small doses. Where we worry about it more is if we're injecting for abductor spasmodic dysphonia, when we're injecting the posterior cricoarytenoid muscles. That's the muscle that opens the vocal folds, which is the most important thing that they do because it provides an airway for passage of air into the lungs. And often actually, when we inject the posterior cricoarytenoid muscles, because there's weakness there, you will have some initially some increased effort breathing. But in any case, I think the incidence of complete paralysis from injecting Botox, as long as we're careful, is very low. And I saw another question before there about it, and to that person, the paralysis would be temporary, obviously, because it's a temporary acting injection.
Thank you. Dr. Gardner, the last time I had a Botox injection, I almost completely lost my voice for a couple of months. I had my regular dose of Botox. Why does this happen? And do you know, would it likely happen again?
Well, when we do, most of us who do the injections use a blind technique where we pass an EMG needle through the cricothyroid membrane up into the vocal folds. We're not actually looking to see where the needle is going. We know which direction to aim the needle. We know there's only a couple muscles in there that we can hit. That is the thyroarytenoid or the lateral cricoarytenoid muscle. So we aim the needle in the correct direction. When the needle is in muscle, we confirm that with the EMG, and then we do our injection. However, we don't know whether the tip of the needle is a millimeter into that muscle, 3 millimeters into the muscle. Are we at the anterior aspect of the true vocal fold, the posterior aspect of the true vocal fold? So with that technique, there's a certain amount of variability from injection to injection. To be more consistent, you would have to use a technique where you can see where the needle is going in, and that would be approaching through the mouth, using a flexible scope through the nose, or doing what some of our colleagues do, which is passing a scope through the nose and then passing the needle from below through the cricothyroid membrane. And then you can be very, very consistent from injection to injection. Many of my patients, however, really don't like the technique where you have a scope in your nose and a needle stuck in your neck at the same time. They find it really uncomfortable. So I tell all my patients that there will be variability from injection to injection. Most of the time, it's really mild variability. You may go 3 months between injections one time and then go 4 months between injections the next time. And most patients will tolerate that amount of variability. So to answer the question directly, it could be that the last injection that person had, it was the absolute perfect injection. The Botox was placed in the absolutely most effective part of the muscle to get the best effect for the longest amount of time. That also causes the great amount of breathiness. And it could be that their previous injections didn't quite hit the sweet spot as much as they had this last time. But most people will tolerate that amount of variability and would prefer that over having the scope pass through their nose or other techniques each time.
Dr. Gardner, just follow up on that briefly. Do you, if you have a person that comes back and said, hey, I have an extended period of breathlessness, do you consider changing the dosage? How do you approach that?
Well, I customize the dosage to each patient's desires, really. It's really up to the patient what they want. So if I have a patient who lives in the Detroit metro area and they have high vocal demands and they really can't tolerate the breathiness, then usually I will give them a smaller dose, and I will just see them more frequently and do their injections more frequently. If I have a patient who lives in northern Michigan, where many of our patients do, and unfortunately there's nobody in northern Michigan who does Botox injections that I know of, they have to travel 2.5, 3.5 hours to get to us. They don't want to come down that often. So for those patients, usually I use a larger dose. They'll have a longer period of breathiness, and they'll go longer. They'll have a longer therapeutic period as well. So, we customize the dosage to whatever the patient wants. And I have that discussion with them each and every time. After they've been coming for a few years, typically they come in, I ask them, how long were you breathy? How long were you good? How long were you bad? Do you want to stick with the same dose? You want to go up? You want to go down? And most of the time they just say, I'm good with the same dose. And we just keep using that same dose for years.
Great, thank you. We've gotten a few questions about the cause of SD. Dr. Berke, do you want to take a stab at that?
Yeah, it's a very complicated issue, and I wish I could say that it's totally understood, but of course it really isn't at this time. There are genetic factors which certainly can play a role. There are certain genes which are dystonic genes, which can be present in family groups. It's conceivable that patients that develop SD undergo some type of insult, whether it would be a flu or a virus or something that might spill it over. Certainly, it seems to be a central disorder, that is to say it's in the brain. There are some people that are looking at the kind of the afferent sensory supply to the speech center that might be disordered in patients with spasmodic dysphonia. It appears that there's an inhibitory center near the speech center that may be not working correctly in some patients and maybe weaker than it might be in normal people. I wish I could give you a definitive answer about that, and unfortunately, it's conceivable that, you know, spasmodic dysphonia is a phenotype. And by that I mean that we know what patients sound like when they have spasmodic dysphonia and what they look like when they have spasmodic dysphonia, but it's conceivable that there could be different etiologies that are causing similar types of voice disorders in different patients. And so, but I would say this, there are some really, really smart researchers that are looking at this issue, and every day they're getting closer to understanding it and getting closer to developing newer therapies that may be more effective.
Great, thank you. We also have a question regarding the use of Botox in pregnancy. Dr. Gardner, do you want to take a stab at that? And the question is, after pregnancy, can it also be transferred in through breastfeeding?
Can the Botox be transferred through breastfeeding?
Yes.
Is that the question? Okay. Well, again, the small doses that we use, this goes back to the question about antigenicity earlier, or developing resistance to the Botox. We use such tiny, tiny doses, we're injecting them in a very specific location, that the amount of Botox that might actually enter the bloodstream is incredibly, incredibly low. I mean, it would be undetectable, assuming we even had a way of detecting it, which I don't think we do. So it's safe in pregnancy when you're using the tiny doses that we use for the larynx. And likewise, it would not be transmitted across the placenta to the baby, nor would it be really found in breast milk in any great quantity. So it's safe.
Thank you. Juliana, I'm not using Botox. I have vocal fry. Is it possible to use speech therapy to relieve that? Higher pitch, resonance therapy, is it just a habit that comes out of using Botox?
So the patient says he or she has vocal fry without getting the injections?
Correct, yes.
Okay. Yes, so when we have someone speaking with vocal fry, which is, for the people who don't know what it is when we speak like this with a super low pitched tone and almost no air. And voice therapy typically responds very well to that. As the attendee said, it's a habit that needs to be broken sometimes. So I even call it a fad. When I used to do voice therapy in a Spanish-speaking country in Argentina for many years, I didn't hear as much vocal fry as I hear here in the United States. I think the intonation patterns of English are different for those two languages, and that adds a little bit more prevalence to vocal fry in languages that have the intonation that goes even lower than the initial sound of the phrase. So if I say, I'm going to the club, I go lower than when I started. And that tends to increase the vocal fry in sentence termination. Now, if a patient is speaking 100% on glottal fry, everything comes out like that, that can be typically easily broken with voice therapy. Adding more air, using, as the attendee said, resonant voice therapy, but basically increasing the airflow. That's the first thing we try to do. I don't know if I have a tissue here. So one thing I try to do with patients that have glottal fry is just ask them to do with no voice and then add the voice in there. And what I hear is, so the tissue's not moving. So we use a lot of visual feedback at the beginning so the patient knows when they're adding more air, because it's something that at the beginning might not be as easy to tell, but with lots of visual clues and just a couple of cues here and there, typically those symptoms go away easily with voice therapy.
Great, thank you. Dr. Mayerhoff, I get unilateral injections of Botox, and I typically get a much better result when injected on my right side. Is that common?
So it's definitely something that is well described. I'm not sure exactly how common it is across different people. Are you able to hear me okay now?
Yes.
Okay.
Yes, that's much better.
The reason can be one of a few. One, your right side just may be more active, and so that may be the side that needs to be treated more. The other is actually technique. Most laryngologists are either right-handed or left-handed and use the same hand to inject either side. And so the angle of approach is a little bit different for each one. And we may be a little bit more skilled about getting to one side than another, no matter how much experience someone has.
Just to add to that, many of us do the injections with the patient sitting upright. We stand next to the patient, and most of us are right-handed. I was at a Voice Foundation meeting years ago and found myself in a cab with 4 other laryngologists and had them captured. And I said, how many of you guys do your injections the way I do it? How many of you are right-handed? And how many of you have more trouble hitting the right true vocal fold than the left true vocal fold? I want honest answers. And everyone in the cab did it the same way. And everybody admitted that they had a little more trouble hitting the right true vocal fold than hitting the left true vocal fold, which was a refreshing admission of fallibility among physicians.
That's great. We've got some questions about vocal essential tremor. Does anyone have any experience using levodopa with a patient that has SD layered with essential tremor? Not sure who wants to take that one.
No, but I think it brings up a point in that, you know, we do involve neurologists, you know, at least early on in patients with this disorder to see if they're, you know, they may have some information in their literature and research that we're not aware of yet. So, but I don't have any experience with that.
And do you see more of a higher incidence of tremor with spasmodic dysphonia?
There, you know, I sort of describe it as a spectrum of disease. They're both movement disorders, obviously. So there are some people who have 100% pure dystonia, and there's some who have 100% pure tremor, and there are many who have something in between, whether they're a little more dystonia weighted or tremor weighted. So yes, we see a fair bit of tremor with dystonia.
The one thing I would add to that is also that sometimes you'll see a tremor that's not really built into the neurologic process, but ends up being more of a compensation that people are working hard to overcome whenever abnormal contractions are happening. And so a tremor happens in response to that. That's part as well.
Great. And then there's a few questions about possible new treatments for spasmodic dysphonia. Any thoughts on the use of Xyrem or deep brain stimulation for spasmodic dysphonia? This might be better for the research panel, but I thought I would throw it out there.
Well, I can comment a little bit on it. Certainly there are studies ongoing now. There's an NIH-funded study, I believe, using deep brain stimulation. And the preliminary results actually look promising in patients with some pretty severe voice disorders. Because the electrodes go very close to the speech center, some patients have to have them the electrical current restructured because they can have issues with speech rather than just their phonation after the deep brain stimulation. And Xyrem is also still being studied quite effectively. I'd probably leave it to whoever is going to talk about it to give you the pluses and minuses of it. But with any drug, there are always things that are beneficial, but there are also some other issues that may be less beneficial. In the instance of Xyrem, without getting into a lot of detail, it doesn't last really as long as one would hope. I think the studies that we have so far show that maybe it's active for about 3 hours, and then its efficacy starts to fade. Also, it has some addictive potential, and the physicians that are prescribing it now, usually under research, are doing so because of that, have to be registered in order to give it to patients.
Great, thank you. And we are doing Facebook Live, and so we've been getting some questions from Facebook Live too. So one of the questions is, can acid reflux interfere with Botox effectiveness?
I can take that. I don't think that acid reflux directly affects the effectiveness of the Botox. However, acid reflux causes a whole a whole bunch of other voice problems. So acid reflux is one of the more common diagnoses that we blame for many voice disorders, chronic throat clearing, raspy voice in the morning, just generalized inflammation of the larynx. So I think it's a separate issue, a separate cause of voice problems, but I don't think it actually affects Botox directly. But if you have a patient who has severe reflux affecting their larynx and you're treating them for spasmodic dysphonia, you may not get as good a voice result as you would like or as you would expect, because the acid reflux could be causing additional problems. So it's important to treat both conditions to get the optimal voice result.
But just as a side note, no one should ever assume that their hoarseness is from reflux without a proper evaluation.
And Juliana, is there a voice therapy specifically targeted for abductor spasmodic dysphonia?
Good question. Sometimes we try specific techniques to try to sustain that vocal fold closure a little bit more, that are the opposite of what we would try with an abductory variant. But honestly, in my experience with abductory variant, it's kind of a trial and error. We try different techniques to try to maximize the airflow and sustain that phonation as much as we can, combined with, as I said before, resonant voice exercises. With the abductory variant, we sometimes try to include some more exuberant closure exercises to see if we can try to interrupt those spasms. But it's always a challenge. Obviously, after the Botox injection, we work on a different scenario. So what I was talking about before is when a patient says, I don't want any Botox, I'm just gonna do voice therapy, which is not common, but sometimes it happens. And it's a trial and error. We see how we can try to compensate for those abductory spasms as much as we can with different sustained phonation exercises and resonant voice exercises too.
Wonderful. Another
Great. Let's, Kim, let's kind of look for a question here and kind of unfortunately wrap up this session. Let me toss out one to the entire panel, if you would briefly comment on this one. And I hear over the past few weeks, and I think I saw it somewhere in the chat box here earlier as well, is when, well, most of us with SD are off work like millions of others. How do we approach going back to work when we sound sick and are often questioned about it under normal circumstances, much less in the pandemic situation? So yeah, maybe each one of you could quickly comment on that. Dr. Berke, you want to start?
Yeah, that's actually a really good question, because obviously, given the pandemic that exists right now, anybody coming in with any evidence of a voice disturbance, somebody would immediately think, oh, they have the virus. And, you know, I think, fortunately, I think if you just tell your friends or your coworkers, you know, I don't have the virus. I just have some disturbance in my voice right now. Other than that, I'm healthy, my fever's fine, and leave it at that. You know, I mean, I think, I would hope at least that in most work situations, adults are smart enough and sophisticated enough to realize that there's not really a connection. And actually, if you look at the symptomatology that they've published for the disease, none of it really includes dysphonia. So I think that it's just a matter of trying to tell them as much as you can. Certainly, you know, your health privacy is a central concern in anybody that you meet, and you, especially at work. And I would just say, you know, my voice is a little off today, but as soon as I can, I usually see the doctor, and it'll be a lot better. Thanks very much.
Great, good response.
Good opportunity to educate others about the disorder too.
Hey, that's exactly, Dr. Rubin is when I get asked that question, that's basically the response I use. And
Yeah.
we have a little trifold card that's available off our website, and I make the comment to people, I never go anywhere without it.
Yeah.
So I use that as awareness and education. Absolutely. Dr. Gardner, you want to add anything?
Just regarding the last question, yeah, as Dr. Berke said, we have not noted that voice disturbances are a symptom of COVID. We have started to see patients who have been intubated for a long time and have survived the disease and have gotten out of the ICU. Those patients are having some voice disturbances. It's because of their intubation, most likely. Some of them are going to have some really serious laryngeal problems, but they're happy to have survived the disease, and we're happy they have, and we'll take care of them as time goes forward.
Juliana, would you like to add anything to that question?
Yeah, it's funny because last week I was doing a teletherapy with a patient with neurogenic cough, and we were doing respiratory retraining to try to suppress the cough. And one of his questions was, how am I going to go back to work and cough in this pandemic scenario? So we were talking about, as Dr. Berke said, informing everyone around you. I've had this problem for a long time. This is how I'm dealing with it. And if you see me doing funny strategies, it's because I'm trying to cope with the spasms or the cough or different things. So informing everyone around us. It can be an email ahead of time before starting going back to work. It can be informing them as whatever manner you please, but I think information is key.
Great, thank you. Dr. Mayerhoff, quickly, anything you'd like to add before we wrap up?
It's hard to add more to what's already been said. I think that really sums it up pretty well. I do think I saw on your website, you're selling masks that do have a little phrase on there that says, I'm not sick, it's a voice disorder. And that's a common thing in patients with all different types of voice disorders, where people will think that they're sick and are worried around them. And certainly that's going to be amplified now, but things like that, you don't have to go into further detail than that. Just say you're being treated for a voice disorder.
Great. Thank you very much. And again, our thanks and appreciation, deep appreciation to each one of you making the time to join us today. And more importantly, again, thank each one of you so much for what you do, help us as in our organization and to help our patient community. So thank you so much, and we will wrap up this session. And,
Pleasure. Thank you.
Take care.
Thank you.
Thank you.
Thank you.
Thanks.